Greetings from Indian Journal of Anaesthesia. I am IJA Vlogger, Dr. Kiran Mahendru, and I'll be presenting an article published in the February issue of IJA. It is a systematic review and meta-analysis on the analgesic effect of intravesical lignocaine in urological surgery. The various analgesic modalities such as tramadol, ketamine, hyoscine, antimuscarinic agents have been administered to reduce the postoperative pain and discomfort from catheter or bladder spasms in urological surgery. Now, continuous bladder irrigation is an ongoing infusion of normal saline to prevent intravesical blood clot formation, wash out the blood clots, and prevent short-term voiding failure. Thus, it also allows proper monitoring of postoperative bleeding. However, it is associated with catheter-related bladder discomfort, which is highly prevalent and is seen in 47 to 90% of the patients due to a variety of risk factors. Catheter-related bladder discomfort may manifest itself as a burning sensation or urinary urgency and pain in the suprapubic and penile areas. It results in aggravation of the postoperative pain, can lead to emergence agitation, and can prolong the hospital stay. And it is usually resistant to traditional opioid treatment. Several studies have investigated the impact of various medications like dexamethasone, tramadol, and anticholinergics in the management of catheter-related bladder discomfort. But these drugs have lack of efficacy and can lead to unwanted adverse effects like increased risk of seizures, visual impairment, and dry mouth. Safe and effective pharmacological agent is essential to attenuate this catheter-related bladder discomfort in adults undergoing urological surgery. Now, lignocaine is a short-acting local anesthetic agent which is safe, cheap, and is commonly used in surgeries. Some RCTs have revealed that intravesical lignocaine approach for bladder wash is associated with lower incidence of catheter-related bladder discomfort. Therefore, the authors hypothesized that intravesical lignocaine reduces the incidence of catheter-related bladder discomfort. The primary objective of this systematic review was to examine the effects of intravesical lignocaine on the incidence of severe catheter-related bladder discomfort among adults undergoing urological procedures. The trial is registered with Prospero. It is a systematic review and meta-analysis with the population included is adult patients undergoing urological surgery, including prostatectomy, percutaneous nephrolithotomy, and TURBT. The intervention was use of intravesical lignocaine, whereas the comparator group was placebo or any other active drug used. The outcomes. The primary outcome of this systematic review was the incidence of catheter-related bladder discomfort among adult patients undergoing urological surgery. Now, the incidence of each study was calculated as the numerator being the number of patients who developed severe catheter-related bladder discomfort and the denominator being the total number of patients in the respective control and the intervention group. The findings from included studies were taken for 2 specific time intervals, which were immediately after the procedure and 6 hours after the drug administration. Now, the 2 points were chosen to investigate the effects of intravesical lignocaine immediately after the drug administration and after the elimination half-life period of lignocaine, which is 1.5 to 2 hours. The secondary outcomes included the incidence of needing rescue analgesia. Databases of Medline, Embase, and Cochrane Central Register of Trials were searched extensively from the starting of the SRMA till 22nd December 2024. The keywords included bladder irrigation, transurethral resection, transurethral, bladder washout, bladder irrigation, lidocaine, and lignocaine. The articles from RCTs that involved adult patients more than 18 years of age who underwent urological surgery such as prostatectomy, percutaneous nephrolithotomy, and TURBT were included. Observational studies, case series, case reports, letter to editors, and conference abstracts were excluded. In addition, published studies comparing intravesical lignocaine and control in vivo in animals or cadaver studies were excluded. The risk of bias was assessed using Cochrane Collaboration Risk of Bias Assessment Tool 2, and the principles of grading of recommendations, assessment, development, and evaluation system was applied to evaluate the quality of evidence of primary and secondary outcomes. Statistical analysis was done using Review Manager version 5.4. Dichotomous outcomes were calculated using the odds ratio and 95% confidence intervals. The heterogeneity of the pooled results was assessed using the I-square test, and due to anticipated significant heterogeneity and small sample size, a random effect model was applied to analyze the data. The current meta-analysis did not evaluate the publication bias due to limited number of included studies. And subgroup analysis was performed to explore the factors contributing to heterogeneity across the included studies. Now, a total of 5 RCTs with a 428 patients in total were included in this review. Now, searching the main registries identified 2 ongoing studies. Now, this is the table showing the clinical characteristics of the included studies. 4 studies administered normal saline as a placebo, whereas 1 study included sufentanil as the control group. In terms of type of surgery, one of the studies involved percutaneous nephrolithotomy, whereas other types of surgeries were prostatectomy, TURBT, or elective transurethral surgery. Now, this is the forest plot for the incidence of severe catheter-related bladder discomfort. Now, pooled analysis from these studies showed that patients who were randomized to receive intravesical lignocaine for bladder washing had a statistically significant decrease in the incidence of severe catheter-related bladder discomfort when compared with the control group, with the odds ratio of 0.27 and a p-value of 0.0008. Now, this is the data for the primary and the secondary outcomes, which included incidence of severe catheter-related discomfort, mild and moderate catheter-related discomfort, and time taken to request for analgesia. Now, as you can see, 2 trials showed no difference in the occurrence of mild catheter-related bladder discomfort, as can be seen that the odds ratio is 1.11 and the p-value is 0.85. Now, the pooled analysis indicated that compared to the placebo, intravesical lignocaine statistically significantly reduced the incidence of moderate catheter-related bladder discomfort. As can be seen, these are the results from 2 trials for moderate catheter-related bladder discomfort with a p-value of 0.003. Now, 3 RCTs with a total of 213 patients were included for this outcome, the time taken to request for analgesia. And the results revealed that bladder irrigation with lignocaine resulted in lower incidence of patients needing rescue analgesia, which was statistically significant. Now, this paper highlighted the potential role of intravesical lignocaine in reducing the incidence of catheter-related bladder discomfort and the number of patients requiring rescue analgesia after urological surgery. Now, the general quality of evidence for all the measured outcomes varied from very low to low, due to the risk of bias, inconsistency, indirectness, and imprecision. Now, the urinary bladder receives the innervation from parasympathetic nerves and hypogastric sympathetic nerves. During the urological procedures, the irritation of the urethra and bladder stimulates the afferent nerves of the bladder. It releases acetylcholine to stimulate the muscarinic receptors, resulting in detrusor muscle contraction due to catheter related bladder discomfort. Now, lignocaine is believed to be responsible for non competitive inhibition of the M3 muscarinic receptors, which can translate into reducing the incidence of catheter related bladder discomfort. The administration of lignocaine is also reported to suppress the production of mucosal COX2 and plasma prostaglandin E2, the most important mediators for contraction of the detrusor muscle. Now, severe catheter-related bladder discomfort, it usually involves strong behavioral responses, such as flailing limbs, trying to remove the catheter, and loud vocal responses. Whereas the criteria for mild and moderate catheter-related bladder discomfort were discomfort reported by the patients during questioning for the mild discomfort and self-reported discomfort without questioning in cases of moderate catheter-related bladder discomfort. Now, these criteria are subjective to the individual patient's tolerance of pain and discomfort, and it resulted in introduction of bias in measuring the primary outcome. So, the outcome may be influenced by variations in the diameter of the Foley's catheter used and the use of adjuvant analgesics. Administration of different types of analgesics like sufentanil and fentanyl in all the included studies and inclusion of patients over 50 years of age can convey a high degree of variability to the pooled estimates. The lack of standardization of diameter of the Foley's catheter used across the included studies may introduce variance to the findings, making the interpretation of the effects of bladder irrigation with intravesical lignocaine difficult. Therefore, future trials are warranted on study of intravesical lignocaine in more homogeneous conditions with similar size of urinary catheters and local anesthesia contents of the lubricants. Continuous irrigation of fluid with lignocaine may provide better pain control to overcome the short half-life of a bolus use of intravesical lignocaine. Due to the variability of the infusion methods and limited number of studies with small sample sizes, the true effect of adding lignocaine to the irrigation fluid on the development of catheter-related bladder discomfort remains inconclusive. The dosage of intravesical lignocaine, which was used in the included studies, varied from 100 mg to 25 mg per hour with no incidence of any lignocaine-related toxicity. Now, the suppression of the inflammatory process by lignocaine is hypothesized to reduce the excitation of the afferent nerves, subsequently terminating the transmission of nociceptive information of pain to the brain. The limitations of the present meta-analysis are there is lack of standardization for defining the primary outcome across all the included studies, which may introduce a substantial degree of heterogeneity. Some major confounding factors were common to other meta-analyses, namely different clinical characteristics of patients, the dose of intravesical lignocaine for bladder irrigation, the timing or duration of intravesical lignocaine used, and various protocols of analgesia used, which are unadjusted in this review. Most of the included RCTs were small in sample size and might be underpowered to detect the clinical benefits of intravesical lignocaine. In addition, the certainty of evidence is low for all the measured outcomes. Therefore, to conclude, the meta-analysis indicated the potential benefit of intravesical lignocaine in reducing the incidence of moderate and severe catheter-related bladder discomfort. Given the substantial degree of heterogeneity with low level of evidence and limited small sample size, strong recommendations for adding lignocaine into irrigation fluid for urological patients is limited. Thus, in future, adequately powered RCTs are warranted to evaluate the use of intravesical lignocaine efficacy and safety profile on catheter related bladder discomfort. Thank you.